Next speaker is Dr. Annapoorna Kini, Director of Structural Heart Interventional Program and Director of Cardiac Cath Lab at Mount Sinai. But more importantly, and of course, Professor of Medicine, more importantly is the person who runs the Mount Sinai, the busiest cath lab of the New York State. In all the way, in the volume, the operation, the safety, and tremendous asset to Mount Sinai. With that note, I'll ask Annu now talk on the update in the transcatheter aortic and mitral valve therapy, knowing the structural heart disease is progressing, rapidly progressing. Almost 20% of our interventions now are structural heart patients. And this field is changing also at the same time. Volume as well as the concepts changing, and where we are now, latest, Annu will present. So Annu, stage is yours.
Thank you, Dr. Sharma. So the future of the transcatheter heart valve, we have 4 valves, everybody knows, and just to let you know that I'll be presenting about the percutaneous aortic valve as well as the percutaneous mitral valve today. So just a basic of aortic stenosis, normal is about 3 to 4 centimeters squared, and when do we get worried? When it is severe, less than 1 centimeter squared, or critical 0.7 centimeters squared. Etiology wise, we are more worried about the bicuspid. Acquired rheumatic we rarely see, but most often that we see is calcific. So if you see here, 5% at 70 years of age, 10% 80 years of age, and 18% at 90 years of age. And we all know once the symptom develops, no matter what it is, your survival is less than 2 years. So this is the concept that came from the guidelines. What is the important imaging that we need for TAVR, and something we all have to know. Currently, aortic stenosis and subsequently referral to TAVR and the management is based on echocardiography, fully based on echocardiography, not invasive catheterization, gradients. So on echocardiogram, what you need to have is your mean gradient should be more than 40 millimeters mercury, mean, or your velocity of 4 meters per second or higher. That gives rise to a severe aortic stenosis. And if your EF is low, then you can do a dobutamine stress echo to determine would your gradient go up. That's the time we say refer for TAVR any procedure. Then what we do is we calculate what is called as the STS risk score, which surgeons usually use it. And based on that, it has been defined extreme risk. If your STS score of more than 15, that is extreme risk, which is about 20% of the patient. If it is 10 to 15, high risk group, about 20, then you have intermediate risk, which is STS of 4 to 10, and anything less than 3 is low risk. Now, why this is important? So if you see here, low risk, intermediate risk, high risk are still operable by surgery. Extreme risk, definitely no. So when the TAVR trials were done, they started with extreme risk. They moved gradually down for high risk, intermediate risk, and low risk. And I'm going to show you some of those important trials. After several trials, the FDA has approved 2 valves in the United States, the core valve and the sapien valve. You guys hear about this when you refer your patients, and we are calling you back to say, yes, patient got this or the other valve. That's all depends on what their anatomy is, what the annular size is, depending on the CT scan. So the first, like I mentioned, was the partner trial cohort B, which was for inoperable extreme risk cases, where there was randomization, standard therapy, patients did not get anything, medical therapy versus TAVR. You see that patients who got TAVR had a better survival, 20% reduction. So after that trial was done, when the core valve came, there was no randomization, but still patients had some kind of mortality in these patients. Based on these 2 trials, FDA approved the TAVR for extreme risk between 2011, which was partner and the core valve was 2013. Then comes the high risk group. Again, same thing, what you see here is a partner trial where they randomized for the TAVR versus surgery, that they were comparable, and for the core valve also, they were comparable. And one thing that we noticed in this trial was that patients who had TAVR had slightly increased risk of stroke compared to surgical. So high risk was approved in 2014. Then came the intermediate risk, similar findings that compared to TAVR and SAVR were equal. Both for the SAPIEN as well as the core valve. So that was approved between 2015 to 2016. Then came the low risk group of patients, where was partner 3, again randomized to TAVR versus surgery. And this is for the Medtronic core valve low risk patients. And guess what we found is that a slightly increased rate of pacemaker in patients who got a TAVR. This was in the Evolute valve. But more important, if you see here, the length of stay, the TAVR was 2.6. And you all know, you all hear from us, the patient is getting TAVR. And whenever you ask us, when is the patient going home? It's usually now about between 24 to 48 hours. And very important that you need to see is aortic valve area, SAVR, you get about 2 centimeters squared. TAVR is larger valve. So based on this trial, this is what the New York Times said, FDA approved TAVR for low risk AS as of July 2019. So we all want, now patients, when they come to see you in the office, they all want is that we do not want open heart surgery. Can I get this procedure done minimally invasive? So yes, it can be done, but there are few things that need to be known, and what are the relatively common risk of complications and infrequent complications. These are very infrequent, which you don't want to know about. Let's discuss about the relatively common. Relatively common is that there is an incidence of stroke, which we say is just below 2% or so. Risk of AV block or pacemaker, depending on the type of valve we use, could be anywhere between 8 to 10%. Of course, the bleeding risk is there up to 5% or so. Paravalvular regurgitation varies depending on the calcium, but these are the common things that you need to know. Now, moving on from calcific valve to bicuspid valve. Now, bicuspid valve is the same thing, that there are 3 kinds of things that we need to know. Is it a single raphe? Then if you have single raphe, is there calcium? So this is mild calcium. This is this calcium in the raphe alone, but no calcium in the leaflet. But if you have calcium in the raphe as well as calcium in the leaflet, that is when you have bicuspid valve. These patients have very high mortality, up to 25% or so, if they had gone had TAVR. So TAVR right now is approved also for this bicuspid valve based on the heart team discussion, depending on the subgroup what these guys are. Now, coming to the outcome, if you see here, tricuspid and bicuspid valve have the similar outcome at 30 days and 1 year. Only thing that has been noticed is that they have a slightly increased risk of stroke when they get TAVR compared to the tricuspid aortic stenosis. So based on the TVT registry, just to give you an outlook of how many places are doing TAVR procedures, as well as the number of TAVR procedures that is happening. So as of 2019, if you see here, over 70,000 procedures being done per year, and the centers are about 700 or so. Majority of the access is femoral. Very rarely is other route are being done for femoral. And the outcome, if you see this, if you see complications were higher, and there is always a learning curve. Right now, look at the outcome at 30 day and 1 year. Everything is less than 3% for these cases. And if you see, the SAVR volume is going down and the TAVR volume is increasing in the United States. This is the registry data. So one thing I think we all have to know, like today, the focus has been on antiplatelet DAPT and anticoagulation therapy. Popular TAVI was just presented. So we all know that when the TAVR trials were done, despite lack of evidence, aspirin as well as clopidogrel was used in patients who had a TAVR for between 3 to 6 months or so. There was no data for that. So what happened is, the popular TAVI was the cohort A, which was first done in this group of patients who require anticoagulation. And then cohort B was the one where they said that they did not need anticoagulation in this group of, this is without anticoagulation and this is with anticoagulation. So the cohort B actually was presented first, and let's see what did it show. So patients without, if you see here, the oral anticoagulation versus oral anticoagulation plus clopidogrel also. If you see here, So patients who had oral anticoagulation, which is with red, had higher bleeding risk compared to just getting a clopidogrel. So what we learn is that try to avoid oral anticoagulation plus as clopidogrel. Then comes, can they get aspirin alone or aspirin plus clopidogrel? So what did it show? Same thing. Aspirin plus clopidogrel arm had higher bleeding compared to aspirin alone. Essentially, this trial is tell us that if for any reason patient needs oral anticoagulation therapy, mostly because they are AFib or any other reason, then you can give oral anticoagulation alone. And if for their need clopidogrel, means many of them would have CAD and you are doing a stent in these patients before TAVR procedure. In that case, you can give aspirin plus clopidogrel, otherwise just give aspirin in this group. So TAVR procedure, Mount Sinai as of 2020, despite what has happened this year, you guys have been very active since you come back from July onwards, referring cases, and we have crossed the numbers of 2019 as of last week, and this is the TAVR outcome of 2019 based on the TVT registry. Compared to TVT registry, look at Sinai data, doing very well in every aspect, slightly increased rates of pacemaker also. Now going back to the guidelines, so if you see here, prohibitive surgical risk, TAVR, class 1 indication. High surgical risk, AVR or TAVR. Then coming to intermediate surgical risk is the same, is class 1 indication TAVR as well as AVR. So there was only class 1 indication surgical AVR in low risk group of patient, but having had the low risk group in a trial presented, even the low risk is going for TAVR. So what we have, even based on the guidelines, every group of patient should be getting TAVR. Now comes the question to all of you. Who should be getting TAVR then? Everybody should be getting TAVR. So low to intermediate STS risk score with extensive or complex coronary artery disease. You have a 68-year-old man who has left main LAD circ RCA lesion and has AS. Maybe it's good he should go for surgery. Now, I showed you the bicuspid aortic stenosis and also the group where in bicuspid, if they have heavy calcium with bicuspid valve, maybe that kind of those patients should go for surgery. Young age, since we don't have the data, what's going to happen to the TAVR valve at 12 years, we have no idea. So maybe those group and a group where concomitant aortic dilatation or needs an aortic route changed or any of these things, heavy alveotic calcium. And if patient has a low to intermediate risk, but bioprosthetic dysfunction, because this group is still not been studied, and adverse anatomy. This is very important. Many of the patients will have adverse anatomy in the sense that they will have lower left main, large annulus. These patients should get surgery. And if they have multiple other valve diseases, which is mitral valve, tricuspid valve, and aortic valve disease, those should go for surgery. I think it's very clear now who should be going for surgery. So the rest, majority of the patients could be referred for TAVR based on the echo. Now moving on to mitral valve, as you see here, mitral regurgitation begets mitral regurgitation. As mitral regurgitation starts, it LV dilates and the mitral regurgitation increases. So about 50% of the patients are referred for mitral regurgitation or so. There are still a lot of patients out there who are not diagnosed and not sent for surgery. So just based on the two types, one is primary, which is based on the anatomy, and the second where your LV dilation, annular dilation, which gives rise to mitral regurgitation. Prognosis depends on the severity, LV function, as well as the symptoms. Now, this is the guideline that has been given. How do we manage these patients with mitral regurgitation? First is that you have to diagnose, again, echocardiogram. If you need anything more, you can then send them to maybe TE or no, but otherwise just echocardiogram diagnosis. And once you have diagnosed them, start them on some kind of a therapy, depending on whether they're primary or secondary. or refer them to the tertiary center where there's a combination of interventional cardiologists, imaging expert, surgeons who will then make a decision what's the kind of treatment these people should get. So just general principle, primary degenerative mitral regurgitation, usually no medical therapy, but then you can refer them for surgery depending on their age as well as the pathology, which can be diagnosed by echocardiogram. Secondary mitral regurgitation is where medical therapy is very important. You guys have to start medical therapy and they're still symptomatic and have heart failure symptom, then they come to us. We will consider whether they need CRT or AFib management. Then we can consider what is the next step. Now, what are the percutaneous therapy that's available for these patients that we can provide now is based on the trial Everest 2, which was randomized to mitral clip versus surgical arm, which showed that the mitral clip was safe compared to the control group, which was surgery. And what it also showed, if you see here, that at 12 months, surgery, on echocardiogram, MR severity was only 2+, but on the device was 3 to 4+ in 18% of the patients. But then when you saw what was the NYHA functional class was only 1% compared to 8% in surgery. Why? Because these patients continued on medical therapy. So just because you saw an echo moderate to severe MR, 3 to 4+ MR, does not mean there's something hazard. That means their functional class also will go down if they're on good medical therapy. This was a survival which showed that after 6 months, some of them actually, got surgery after that also. They did very well in them. Just a case presentation here. This is a 79-year-old female who had a dilated cardiomyopathy, had multiple comorbidities, and had symptoms, progressive as well as very limiting. So echocardiogram shows severe mitral regurgitation here. And this is a 3D echo showing, you see the anterior leaflet that is prolapsing. So this lady, she has a combination. This was a mixed. She had primary pathology, which is the anterior leaflet prolapse as well as a dilated LV. So ended up with the 3 clips. If you see here, you can see she had 3 clips. She already had also CRT done before she got the clip therapy. And after that, she actually has been done well. After clip, you can see that the MR reduced to 1+. And here is a 3D echo showing you 1, 2, and 3 clips right here in this patient. Also, we do invasive monitoring. The V wave, which was 8 after 3 clips, went down to 20. When we are doing the clip and we are releasing the clip, before we release, we always make sure that there is no gradient across the mitral valve, that we are not causing stenosis, trying to decrease the mitral regurgitation. Once we are sure that there is no stenosis, we release the clip and go subsequently. 2 important trials that we need to focus on based on the mitral valve therapy in heart failure for secondary MR, which were presented. One was the COAPT and other one was the MITRA FR. MITRA FR was first presented. And if you see here, the same thing, patients who had a mitral regurgitation, who had heart failure. Only thing here was patients got a clip as well as treatment at the same time. So about 307 patients underwent randomization to medical therapy alone or who got the clip. So 96% of the patients, there was a successful clip placed, whether it was 1, 2, or 3 clip in this patients. So what did this trial show? No difference, whether it was clip or patients had a good medical therapy in these patients. Then let's go to the COAPT, which was done, that MITRA FR was done in Europe. COAPT trial was done in the United States. Same thing, mitral clip plus GDMT. And this is guideline medical therapy, guideline directed medical therapy, about 305 patients or so in each group. So what you need to know in this patient is, you see here, patients with heart failure, moderate to severe mitral regurgitation, who remain symptomatic despite maximal tolerated GDMT. So you have to say that first patient have to be given medical therapy. If you see this group of patients, multiple comorbidities in this group of patients. Look at their BNP on treatment over 1,000. That means these are real sick patients. And if you see NYHA class in this group of patient was about 3 to 4 NYHA class, 2 to 3, despite on therapy also. So this is the important slide, which is showing medication use at baseline. Majority of them, beta blocker, ACE inhibitor, mineralocorticoids, nitrates, or any kind of diuretic was used in this patients. So then patients who got clip, which is between 2 to 3 clip, in majority of this patient, there was a success rate of close to 95% or so. So the primary effective endpoint was all hospitalization for heart failure within 24 months. And there was 25 to 30% reduction in all hospitalization for heart failure patients who got clip compared to medical therapy. All-cause mortality was also lower. First time the device trial showing that there is a benefit of mortality patients who got the clip. So if you go over adverse event within the first 24 months, what did it show? That LVAD or heart transplant patients who were with severe mitral regurgitation actually benefited from getting this therapy. Now, this is what the two trials shows. In one trial, you saw compared to guided medical therapy, mitral clip patients did better. In another trial, there was no difference at all. Both the medical therapy as clip patients did same. Question comes, what was the difference and why was it different? So if you see here in patients with MITRA-FR and patients with COAPT trial, this is the mean EDP, which is telling us that in MITRA-FR, patients were almost end stage, dilated LV. Look at their EROA was more than 30, here was more than 30, but here more than 20 millimeters squared. So based on that, there was this editorial that was written, what is proportionate and disproportionate MR in these patients who had a functional mitral regurgitation. So if you see here, EROA is here, but this is the end diastolic volume. So patients with mitral regurgitation had a high end diastolic volume. Basically, we're telling they had a dilated LV or end stage burnt out LV compared to patients with COAPT as disproportionate MR. There was still some contractile reserve there in the LV, and that is how they developed, they had some mitral regurgitation. So when you fix, they have to be fixed at the right time. Don't wait till they are in the end stage when it's very late. And when you try to fix it, then you may not see any difference in this group of patients. So based on the COAPT trial, mitral clip was approved by FDA, and we are waiting for a CMS approval. So but right now we are doing mitral clip on patients who have a functional mitral regurgitation. Another group of patients who already have a prosthetic mitral valve, and if they have any dysfunction, can we do something to them? Yes, valve-in-valve patients were what we say. We can do the valve, percutaneous valve in patients with dysfunctional mitral prosthetic valve. And this is just to show you case example, 77-year-old female who had symptoms, who had a transgradient mitral valve. If you see here, stenotic mitral valve here, this is the prosthetic valve that you can see in the mitral place. So we do it percutaneously, transeptal, go there, and you can see how we are placing the sapien valve right in the mitral position. So this is the final result, how it looks. 2D echo, where you can see that's nicely opening. This is the pre and the post. So this was a stenotic valve, and now you can see the valve that's opening very well. So the landscape, just to say, for mitral valve patients who are native, just to say there are several other valves that are out there. Many of these are under trial, but you have to know the anatomy of the mitral valve is very complex, and also we have to know the way the valve is placed. And there is the new thing that we say, that is a neo-LVOT that can be created depending on way the valve is being positioned. So that is why, unlike TAVR, replacing native mitral valve is still undergoing a trial, and in years to come, we may be able to overcome that. So right now we are doing with the apical axis, there is a risk of LVOT obstruction, valve thrombosis, and as well as a perivalvular MR, but more important is that it can be embolized the way it is being placed. So there's still a lot of challenges we have. So just for the conclusion here, mitral clip has been approved for degenerated mitral valve, and I just showed for the functional mitral valve also, we can do mitral clip, but very important, these patients have to be on good medical therapy first. So we may, when you refer the patients to us, based on the CMS guidelines, we may say the patients have to be seen by heart failure. If that's the way the CMS will make the requirement. I don't want you guys get offended saying that we are managing the patients well. Why now a heart failure person has to see? But if those guidelines are telling us that's the way you have to do it, you will hear from us that yes, these patients have to be optimized a little bit more, and then they can get the treatment. For TMVR, valve in valve, for SAPIEN valve, which I showed you the case, it's doable and we can do it. So TMVR utilizing for native MV has mixed result, and a lot of trials are ongoing. So these are the things that randomized trial, and we will probably have to wait a couple of years before we see how this field is moving. Thank you for your attention.
Fantastic overview. And any questions? So just to say, the tower kind of has gone to the final, has taken off. Maybe about 5% overall patients go for surgery, or between 5 and 10%, but in the mitral space. So question will come, Anup, that if anybody asking for, encouraging our participants to put a question in the chat, that what determines how long should be the guideline directed medical therapy in the functional MR before decision is made for the mitral clip?
That is at least 2 weeks. By the time we start the medication, okay, and we see some difference, will be 2 weeks. But we say by the time we start medication, they come and see us again. We have to document that they still have symptoms or medication. So we are making it between 4 to 6 weeks. So anywhere between 4 and 6. But I think on the trial data was at least 2 weeks, they have to be on therapy. There is a question about antiplatelet therapy in tower patients on anticoagulation for AFib. Can we get rid of all antiplatelet treatment based on the current data that I just showed? Yes, if they're on AFib and they are on a NOAC, you can get rid of it. Get rid of aspirin or Plavix. But if the patient has concomitant CAD and stent, then maybe we decide you'll continue on NOAC and Plavix.
Absolutely. So single, more and less. While compared to the patient with MI, we are adding new and new medications. For rest of the therapies, whether PCI or tower, we are trying to cut down our antiplatelet and anticoagulants. Fantastic, Anu. And really thank you for excellent presentation.